Henoch Schonlein Purpura. It's a type of IgA vasculitis and it's the commonest vasculitis of children. It affects the small vessels, producing leukocytoplastic vasculitis with a classic triad of non-thrombocytopenic purpura, large joint arthritis, and abdominal pain. It's diagnosed clinically by the characteristic distribution of the rash, palpable purpura over the lower limbs, extending onto the buttocks, but it can also involve the upper limbs, trunk, and even the face. Case scenario: a 7-year-old boy present to the emergency department with abdominal pain and a rash on his lower limbs for 3 days. In history of presenting illness, rash, non-itchy, started on both lower limbs, spreading to buttocks, described as red-purple spots. Abdominal pain, intermittent cramping associated with vomiting but no diarrhea. Joint pain, complaints of knee and ankle pain but no swelling or redness. No fever, no weight loss, no night sweats. Past medical history: recent upper respiratory tract infection 1 week ago. No history of allergies, trauma, or similar episodes in the past. Family and social history: no family history of autoimmune diseases, lives with parents, attends school, and has normal growth milestones. Systemic review: no urinary symptoms or hematuria noted by the parents. Examination: general appearance: alert and interactive. No pallor, jaundice, or lymphadenopathy. Vital signs: temperature 37.1, heart rate 90, blood pressure 100/65, respiratory rate 18. Skin examination: palpable purpura on both lower limbs and buttocks. No signs of active bleeding or bruising elsewhere. Abdominal examination: mild tenderness in the periumbilical region without guarding or rebound tenderness. Bowel sounds present. Joint examination: no visible swelling, erythema, or warmth in knees or ankles, but tenderness on palpation. Cardiovascular, respiratory, and neurological examination are normal. Differential diagnosis: Henoch Schonlein Purpura (HSP), idiopathic thrombocytopenic purpura (ITP), leukemia, meningococcemia. Investigations: essential test: blood test, full blood count, assess platelet count, white blood cell count, and hemoglobin levels. CRP or ESR, check for inflammation. Coagulation profile, rule out coagulopathies. Renal function test: urea electrolyte creatinine and urinalysis to check for hematuria or proteinuria. Abdominal ultrasound, evaluate for intussusception. It's a complication of HSP. Management plan: confirm diagnosis based on clinical features and investigation results. Symptomatic management: pain relief, paracetamol or ibuprofen if no renal involvement. Hydration: ensure adequate oral or IV fluids. Abdominal pain, monitoring for complication like intussusception. Monitor renal functions. Follow up urinalysis and blood pressure over weeks to months. Referral: pediatric nephrologist if renal involvement is suspected. Key points for role play: empathy, reassure parents that HSP is self-limiting in most cases. Education, explain the disease, its typical cause, and signs of complication: severe abdominal pain, blood in urine, or swelling. Follow-up plan: ensure the parents understand the importance of monitoring the child's urine and blood pressure regularly.